Good morning all, I'm Ishwarya, occupational optometrist from Shankar Netralia. I'll be presenting on the topic, the impact of environmental factors on tear quality and cellular changes along with its ocular manifestation among the outdoor workers. So start with UV radiation is a part of an electromagnetic spectrum that is divided into A, B and C depending on their wavelength. And as these radiation transfers the ocular structures, it causes potential damage to the tissue. Air pollutants, especially the particulate matter, impacts the quality of life and leads to about 7 million premature deaths per year. When these pollutants come in contact with the ocular surface, it causes toxicity, oxidative stress, leading to loss of immune tolerance, increasing the pro-inflammatory cytokines, and therefore tissue damage. The environmental insults, like the ambient air pollution and ambient UV radiation, has various influencing factors like altitude, latitude, air quality, aeroallergen, and the combined effects are presented as acute changes in the eye with photokeratitis, photoconjunctivitis, irritation, discomfort, which in long-term exposure causes pterygium, cataract, dry eye syndrome, meibomian gland dysfunction. And our interest was pingucular pterygium and cataract, where pinguicula is a yellowish, non-malignant degenerative growth and precursor of pterygium, where pterygium is a fibrovascular dysplasia on the bulbar conjunctiva, usually located in the nasal horizon due to the corneous effect. And cataract is the modification, aggregation, precipitation of protein crystallines, which prevents the clear vision and leading cause of visual impairment and blindness all around the world. So existing literatures on these environmental influences like UV radiation and air pollution have reported that there is a strong evidence or positive association of these environmental influence on eye, resulting with cataract, pterygium, climate droplet keratopathy, pseudoexfoliation, etc. And the biochemical changes that has been observed due to these environmental influences were aqueous tear film deficiency, changes in the cytological level, that is the DNA damage, and reduce in the tear quality, quantity, and diminished levels of interleukin factors, which are the intermediary factors in the tears. So the aim of our study was to evaluate the effect of chronic air pollution and lifetime UV exposure on ocular surface and its related cellular changes among the outdoor workers in Tamil Nadu population. This was a prospective observational study where we included subjects who were working outdoor for more than 5 years and excluded those with any history of trauma, glaucoma, and 10 number of migrations to assess the consistency of UV exposure and air pollution. So we started with a comprehensive ocular examination, then we did a clinical data collection and the biochemical analysis, where I'll be explaining all this in detail. So the air quality index was collected from the central and pollution control boards, and UV dosage was taken from the TEMIS software and then substituted in the effective formula to obtain the cumulative levels of UV exposure for all the lifetime period. And the conjunctival damage was assessed with a bespoke device called as conjunctival autofluorescence photography tool. This helps in assessing the collagen that has been damaged due to the UV exposure, which gives the autofluorescence, and then the images were analyzed using ImageJ software to understand the preclinical damage where ocular manifestations are yet to develop in those patients. Impression cytology was done with the asymmetric filter papers, that is cellulose acetate paper, and these cells, the conjunctival cells, were dislodged from the cells, and then we had done an enzyme immunorapid assay detection to identify the CDP damages, and tear cytokine levels were analyzed using the multiplex immunoassay, which is a ELISA technique, and both are kit-based methods to understand how much was the DNA damage and how much was the interleukin levels in both. The statistical analysis was done and appropriate statistics were applied. Our results show that among the 337 participants, the age, occupation, conjunctival damage, UV dose exposure, and air quality was different and significant among the various groups that we had observed. Systemic disorders or personal habits and literacy status did not show any difference among the participants because all were from the same group, from the same location. So Shimmers, it is a tear quality test which did not show any significant difference between the disease group and control group, but the tear breakup time, which is done prior to Shimmers, illustrated a significant difference between the disease group and control group, indicating reduced tear quality in those with exposure to environmental influences. Air quality has shown a difference between those with disease category and control category, with cataract being the highest, and conjunctival preclinical UV damage was significantly different, with the pterygium being the highest. For about 42 mm of damage were observed, and it was significantly different. UV-induced DNA damage in conjunctival cells that was assessed with the impression cytology showed a significant difference between the deceased and non-deceased group, with pterygium again being the highest. Measurements of cytokine levels in the tears exposed to air pollution were assessed with the kit-based method, where the interleukin 6 and interleukin 10 did not show any significant difference. However, TNF-alpha factors, that is tumor necrosis factor, showed a significant difference among the disease group and the control group, with again pterygium being the highest. So regression was done to analyze the risk factors and protective factors, where we have seen that the increasing age, location, literacy status, and lifetime UV exposure, along with the conjunctival damage, was a risk factor for the development of these environmental influencing diseases such as cataract, pterygium, pseudoexfoliation, etc. And the protective factor was TBUT. What I mean to say is when the tear quality and quantity was high and it was good, there were a chance to protect the development of the diseases. And from our study, we have found that age, location, literacy status to be a risk factor, which is similar to that reported in the previous studies, that is one done in aborigine and non-aborigine Australian population, and one done in India by Rashima et al. And the QF was high, representing a strong association of ophthalmoliosis, those UV spectrum disorders, and the preclinical conjunctival damage that was equivocal in the previous studies, which was noted by McKnight and Sherwin et al. So, Pockrell and Jeong had reported that long-term exposure to PM levels had a strong association with cataract formation and other UV spectrum disorders. Similarly, we recorded 3 years archive data which showed the AQI to be a significant difference in those who developed the cataract disease, but we did not find any risk with association or development of the disorder. Perhaps more longitudinal data of AQI would help in understanding how is the disease affecting the development or exposure. Augusto had reported that the ambient levels of air pollution impacts the conjunctival goblet cell density and reduced OSDI scores, which is reduced the tear quality scores in developing the dry eye disease. In our study also we reported reduced tear qualities indicating the reduction in the quality and quantity of tears and further leading to dry eye disorder, hence development of ocular surface disorders. So in this study, conjunctival cells from impression cytology showed a UV-induced DNA damage indicating squamous neoplasia or limbal cell deficiency, which is similar to that reported by Ranjana et al. And high levels of PM 2.5 exposure is associated with decreased levels of IL-5 and IL-10 levels, suggesting modulatory action of ambient air pollution on ocular surface immune responses. And in our study, we could not find any significant difference between the IL factors, but there was a significant difference with the TNF-alpha between the disease group and control group. So the clinical relevance from our study is that preclinical detection of UV spectrum disorder or any detectable conjunctival damage can reduce the global burden of blindness in case of untreated pterygium that can progress to invasive carcinoma, that is a type of cancerous cells, and leading to disability adjusted life years and reversible blindness due to cataract. And Schimmer's test or tear osmolarity test can be more relevant to the clinicians in diagnosing the ocular surface diseases with increased level of inflammatory cytokines and in mediators. Thank you one and all. I'd like to acknowledge ICMR for funding the project.
So, Mr. Speaker, very unique study. I mean, there must be very few occupational optometrists in India.
Yes, sir.
You're one of them?
Yes.
Great to know that. Any question, please?
Yes, sir.
Both the speakers are basically doing observational longitudinal studies.
Yes.
Measuring the risk is basically cross-sectional. So a value addition is basically, if you try to do a time to event analysis to measure the risk between a time period.
Yes, sir.
To estimate the risk and the incidence rates as and when the event occurs.
Okay, sir.
More value addition, because now we are at a point in time.
Yes, yes.
And that's not right in a observational study, which is not.
Okay, sir. Yes. Okay, that is a prospective. I mean that we have collected prospectively and only for the AQI data.
You have to collect for the same sample of the same patient in multiple times. Your data collection won't happen on a single day. It would happen over a 6 month period.
Yeah, it's almost 1 year time.
6 months you are collecting sample from different patients. It is again process. For same patient, if you are collecting a 6 months, 1 year, 2 years, it will be
Prospect, okay.
Thank you for the guidance.
You are saying the risk at the end of 6 months.
Yes, sir.
What we should say is, what is the risk between the start and the 6 months? What is the risk at any given point in time?
Understood, sir. Yes, sir.
And you get vetted by a qualified epidemiologist or a statistician.
Okay, sir.
I don't think you have a statistician or epidemiologist who can be tried.
A statistician, we don't have as such, but yes.
So because since ICMR is funded, I don't know how because I find this all technical objective and a methodology.
Okay, sir, I
It would have
understand.
been defined at the conceptual stage itself.
Okay.
Then you would have better result with the same equipment, same effort that you made. You made a lot of effort, no doubt on that.
Yes,
And
sir.
the concept is worth exploring further.
Yes, yes.
Evidence obtained is not through established statistical methods. That's what I think.
Okay, sir.
Thank you. This is a forum where we keep on learning and sharing our views.